All right, everybody. We've had a few little technical barriers, but we're almost there. We've got a couple of great talks today about rapid diagnostics, so hopefully that will keep everybody entertained. Just do a little bit of tweaking. While we're waiting, I'll just do acknowledgement of country. So University of Queensland acknowledges its traditional owners and their custodians of the land on which we meet. We pay our respects to their ancestors and their descendants who continue cultural and spiritual connections to country, and we recognise their valuable contributions to Australian and global society. So first up, we've got a couple of great speakers for you today. First up, we've got Dr Shradha Subedi. She is an infectious disease physician and medical microbiologist based at the Sunshine Coast, which is also doing her PhD with us here at UQCCR, and is doing lots of really interesting work, particularly around rapid diagnostics of central nervous system infections. So she's presenting remotely from the Sunshine Coast. So hopefully we'll get you, Shradha, to try and share your slides when you're ready.
So thanks for the introduction, Patrick. As Patrick said, I'm based at the Sunshine Coast, so hence presenting remotely today. And thank you for the opportunity to present today. Look, Patrick's already acknowledged the country, but I'm, here at the land of Gubbi Gubbi people, so I too would like to acknowledge the traditional owners of the land and the custodianships, and recognise their valuable contributions to Australian and global society. So today I'm going to talk about central nervous system infections and rapid diagnostic tests, particularly with regards to syndromic panel testing. So we'll talk a little bit about CNS infections, what syndromic panel testing involves. I'll talk about our clinical study on BioFire meningitis encephalitis panel. I'll present some of the preliminary results, just noting that this study is still going analysis, and I've got a concluding slide as well. So I guess we all know that CNS infections, and I'm talking about community-acquired bacterial meningitis and encephalitis, they're serious conditions with significant morbidity and mortality. In fact, they're the fourth largest cause of disability-adjusted life years globally. And I guess worldwide, when we look at laboratory diagnostics, microscopy and culture, and in many cases, antigen detection methods are available more readily, even in smaller laboratories, but often these methods are limited by sensitivity. And really, nucleic acid amplification testing is sort of like the gold standard for pathogen detection from cerebrospinal fluids. Getting a rapid result from CSF may help with getting early targeted therapy for patients. And particularly if you've got a negative PCR, it may enable clinicians to stop any unnecessary antimicrobials. CNS infection is a global problem, and it is there is a WHO global roadmap to defeat meningitis by 2030. And I guess one of the things, there's 4 different pillars of global roadmap, and one of them does involve diagnostic testing. So development, wide availability, and implementation of appropriate diagnostic tests is one of the goals of WHO. So I guess when we look at syndromic panel testing, these sort of in the last decade have really taken over. There's lots of different syndromic panels available for various different infections. We're talking about commercial panels, which are multiplex, so lots of different targets. And I guess one of the advantages of using those panels is that you're able to detect potentially multiple pathogens simultaneously. Often these panels have very short laboratory specimen handling time, and also shorter turnaround time to results compared to sort of in-house laboratory developed tests. The other advantage particularly is that they don't need sort of complex laboratory infrastructure, so potentially useful in labs that don't have a molecular microbiology setup. And over the last decade or so, these sort of panels have really taken over. They're available on blood, CSF, synovial fluids, respiratory samples, feces, to name a few. So when we think about syndromic testing on CSF, some of the advantages are that you only need a small volume of CSF. That's particularly useful in pediatric patients. They also, improve laboratory efficiency. So often when clinicians see a patient with suspected meningitis, they sort of form a hypothesis that this may be viral meningitis. So if you've got sort of single-plex testing, then they may request viral PCRs, and if they come back negative, then they may add on extra tests. So sometimes they can add to the workload in the laboratory. But having a one-stop kind of testing will also simplify test ordering for clinicians. So you've got a panel that has, 8, 10, 12, 14 targets, and they get those results. And obviously, rapid results are definitely a pro. A lot of these panels, the actual capital investment of the instrument, they're expensive, but also sort of ongoing testing with the pouches can also be quite expensive. And depending on different targets, they have varying sensitivities and specificities reported. And with some of the panel, there's conflicting data on clinical outcome. And I guess some of the studies suggest that when you introduce these panels, it can lead to overuse because of because of the panels being readily available. So you need to have some kind of stewardship, clinician engagement, and work collaboratively with the clinicians as well. So for CSF, there are a number of different commercial PCR assays that are available. I've just listed a few, but there are a lot more. So for example, Cepheid, GeneXpert, there's an intravirus assay on the CSF. There's a diasorin kind of viral assay with HSV1, 2, and VZV. I guess although these panels have good laboratory concordance, their use is limited by the sort of limited number of pathogens detected. And a lot of these assays don't have very good clinical outcome data. There is a multiplex syndromic panel, QIAstat, which is developed by QIAGEN. It's a meningitis encephalitis panel, similar to the BioFire FilmArray panel, which I'll be discussing. This one also has a larger number of targets, but and has got some good laboratory data now become available. But again, we don't have. It's a fairly sort of newer panel compared to the BioFire panel, so we don't have studies on clinical outcome. And as far as I'm aware, I think it still doesn't have regulatory approval in Australia. So the BioFire FilmArray meningitis encephalitis panel, which we used in our clinical study, does have regulatory approval. And again, it's a sort of multiplexed, fully enclosed panel with bacterial, viral, and 1 yeast target for Cryptococcus. Requires only 200 microliters of CSF and has 14 targets, 6 bacteria, 7 viruses, and 1 yeast, which are listed on the right. They're probably the more common causes of community-acquired meningoencephalitis in Australia. Turnaround time is about an hour from when the specimen goes into the instrument, with just a very minimal specimen handling time. Overall, good laboratory concordance with some sort of, discrepancies. So some of the laboratory studies have reported higher limit of detection for HSV1, so potentially lower sensitivity for HSV1. There are some studies suggesting some specificity issues with some of the bacterial targets, particularly Haemophilus influenzae, Streptococcus pneumoniae, and Strep agalactiae. And it's known that this target has a lower sensitivity for detecting cryptococcal DNA. So, clinicians should always request an antigen test if there's a high clinical suspicion of cryptococcal meningitis. So at the Sunshine Coast, where we don't have a molecular lab, there was a lot of interest from our clinicians on having something available for CSF on site. And I guess the main concerns were turnaround time to results, and particularly for our pediatric patients, that would often mean sometimes recannulating babies for whilst waiting PCR results. And also, the concern of sort of ongoing antimicrobials, particularly antiviral medications. We know that meningitis has significant morbidity and mortality. It's also a very emotive diagnosis. It's got public health consequences for some pathogens like Neisseria meningitidis. So having that earlier diagnosis does kind of provide earlier, public health intervention potentially, but also peace of mind for parents and families when they can say, well, it's just viral meningitis and it's not, meningococcal, for example. There are some gaps in the literature about how this panel would fit in a non-metropolitan type setting. And I guess it's fair to say that needs, benefits, and consumer expectations are different in metropolitan versus non-metropolitan settings. So before our study, molecular testing is predominantly centralized in 2 main laboratories in Queensland. So CSF PCR testing is done in, or was predominantly done at Central Laboratory in Brisbane, but also in Townsville. So many other laboratories would refer to Central Laboratory for testing, which is what we did at Sunshine Coast as well. So the study that we did is based at the Sunshine Coast Hospital and Health Service. For those who are not from Australia or not familiar with Sunshine Coast, we have a large tertiary hospital here, which has just exponentially grown over the last 5 to 6 years. And we also serve several satellite hospitals covering up 1,000 beds in this region. It's a rapidly growing region. It's about an hour and a half from the main city in Queensland, Brisbane. On site, we have a medical microbiologist 5 days a week, and we have an ID service 24 hours a day, 7 days a week. So when we sort of thought about doing this, we considered the BioFire ME panel and also considered some of the potential considerations or issues that may come up if we implement this panel in our laboratory. So I guess the main things, to consider were, regulatory approval, which this asset already had approval for before we started the study. And then the other thing was laboratory verification. And fortuitously, when we thought about doing this study, the Central Laboratory was also considering using this panel for a select group of patients. So the panel had already undergone full verification in the reference laboratory. So further verification was carried out in the SCU micro lab. The test performance is something that always comes up, particularly with regards to the lower sensitivity of HSV1. And that is something that we have to consider quite carefully, as well as some of the specificity issues that may come up. And a bit unclear, I'll talk about a little bit unclear why that specificity issues may be. But with regards to the HSV1, we focused on really sort of doing a lot of clinician education, informing them about the potential limitation of this test. Ideally, in all labs, in all laboratories, molecular laboratories, microbiologists review all positive results, but we also review all the negative results, just in case if there were any that needed in-house testing, but also even though this is a multiplex panel, obviously it doesn't cover every single pathogen. So just to ensure that we tested for anything else that wasn't available in the panel. And for, we also had some measures and strategies in place for suspected false positive or false negative result. Obviously, cost of an assay is a concern. So we had some diagnostic stewardship measures in place, but we were planning to do a thorough health economic analysis as part of this study. And then diagnostic stewardship, with those studies showing that potential for overuse, we had a laboratory testing criteria. We did some test monitoring during the implementation phase, and also a lot of clinician education and feedback. So this is our study methodology. So it's a quasi-experimental pre and post study. We understand it's not in the ideal world you do an RCT, but it gave us some information about how this, what an implementation of a panel like this would look like. So essentially, we included all patients with suspected community-acquired meningoencephalitis. So in terms of CSF inclusions, we had patients who had abnormal CSF white cell count and or abnormal biochem, so low glucose or high protein. We excluded all patients that had abnormal CSF due to a non-infectious cause or those with healthcare-acquired meningitis. And if the BioFire panel was done in the last 7 days, we just ensured that the request was vetted by a clinical microbiologist first. Exceptions were pediatric patients less than 12 months and patients also in ICU and pediatric critical care unit, where we tested as per request. So in terms of implementation strategies, as I mentioned before, clinician education, quarterly review of results and test ordering patterns. We also did some clinician surveys, and I'll show you some results later on. And we are currently doing some clinician interviews as well. So before the implementation of this panel, all CSF PCR requests that were received in our laboratory were referred to Central Laboratory in Brisbane, where the turnaround time to results was approximately 24 hours. We collected data for 12 months on these patients. We were planning on a 6 to 8 week washout period, but due to sort of unforeseen kind of circumstances, our washout period was quite prolonged, about 8 months, but that gave us a good opportunity to really think about some of those implementation strategies and make sure that our laboratory was ready to go. And after implementation, testing was done on site with a turnaround time to results for about an hour. And we collected clinical data for about 12 months. And the outcomes were clinical outcomes, including sort of total antimicrobial dosages, length of hospital, ICU stay, and all-cause 30-day mortality, health economic, including total costs. And we also described some of the implementation considerations. So I guess in the laboratory, some of the things that we had to consider were, obviously laboratory verification, staff training, staff education, ensuring that there were some interpreted comments for the PCR results. There are some studies that have reported potential contamination, even with, I guess, a black box assay like this panel. So we ensured that we had a dedicated biosafety cabinet and also co-location of the instrument next to the biosafety cabinet. We focused on staff training, PPE, glove changes, cleaning, and we had lab staff education on testing guideline. So in cases where CSF PCR was not performed, we had a interpretive comment that was added, and that all the requests were reviewed by medical microbiologists and often discussed with clinicians when a PCR was not performed. As I said, we reviewed all positive and negative results. If the CSF was clearly abnormal and the BioFire results were negative, often the medical microbiologists would discuss with clinicians about doing additional testing, such as an in-house HSV PCR if there was a high clinical suspicion of encephalitis. Sometimes other tests like flavivirus or TB, for example. So we had this organizational readiness assessment, which we filled out each quarter during the study, which looked at various sort of factors such as support, governance, stakeholder management, and we sort of wanted to make sure that we were on track throughout the implementation. We also had a clinician handout. It was just a double-sided page that we distributed every quarter during the implementation phase of the study. We had a meeting before starting with all clinical key groups, so ED, neurology, infectious diseases, general medicine, pediatrics, ICU, particularly discussing around the targets, some of the limitations. We took some minutes. We had sort of quarterly meetings with most of the key groups, feedback about some of the results, and we also performed some surveys with the key clinician groups. So I guess when we talked about rapid diagnostic tests, some of the principles that we sort of wanted to get across all the clinicians was, just because you can doesn't mean you should. I think sometimes when you have these syndromic panels available, there is a desire to sort of request tests easily. So both from the clinical perspective, but also from the laboratory perspective, it was important that we carefully integrated what was technically feasible with what is clinically important. It was important that we looked at some clinical impact studies, and in terms of implementation, really to understand who to test to maximize outcomes, that we did some cost effectiveness analysis and engage the clinicians in that process. So I just want to present some of the preliminary results, noting that this is, we're still doing the analysis. So in the 12-month period, we had 189 patients in the conventional group and 221 in the BioFire group. Now, whilst it looks like we've probably got more patients in the BioFire group suggesting sort of potential overuse, we've also had an increase in laboratory testing in that period by about 20%. We did have more pediatric patients in the BioFire group suggesting potentially the pediatric patients, there's, potential tendencies to overorder or overuse the BioFire panel. In terms of the ICU admissions, they were similar between the two groups, and our median length of ICU stay was similar. Now, interestingly, our total positive was 15.8 in the BioFire and 80.5 in the conventional group, slightly higher. And we actually had a run of pericovirus that year, and potentially that might have contributed to that slightly higher in the conventional group. And intravirus was the most common pathogen detected in both groups. Now, in our BioFire group, we had 13 CSFs that we sent for some repeat testing, in-house testing, 11 of which were for HSV 1 and 2. And this was often vetted by a microbiologist or requested by a clinician, and they were all negative. In terms of pathogen detections, as I mentioned before, intravirus was the most common, but we had a smattering of different targets detected in all groups, including HSV 1 and 2. Parico, and as I said before, we had that run of Parico that year in the conventional group, VZV, meningococcal, strep pneumoniae, and strep atelectae. In terms of median length of stay in hospital, they were similar between the two groups. And when we looked at antimicrobial total dosages, we had a lower acyclovir in the BARFA group, particularly in the pediatric patients. There was no major differences in the antimicrobial use, except for noting that there's a higher third-generation cephalosporin use in the BARFA group. And we can probably discuss that a bit later, but that's interesting to note, and hoping that we will be able to clarify that with our clinician interviews that are happening right now. The total cost was lower in the BARFA group compared to the conventional group, and that applied for both pediatric and adult population. In saying that, when we did regression for clinical factors and demographic factors, there was no statistically significant difference in costs between the two groups. As you can imagine, both groups had a very heterogeneous kind of patient characteristics. And as I mentioned before, we did 4 surveys during the study. The first survey was really to try and determine how clinicians in our health service requested PCRs, and it was to gauge how they felt about rapid PCR. And 77% of the respondents from the first survey reported that they see a patient and order PCR, irrespective of the microscopy or biochem results, so they base it on their clinical judgment. So it also meant that we needed to have some kind of laboratory testing criteria for CSF PCR requests. As it often happens in study, 2, 3, and 4 surveys, we had less respondents. People get a bit of survey fatigue as they go on. But surveys 2 to 4 was really just to try and determine the clinician's trust in the results and the assay, and try and get a feeling for how the implementation was going. And throughout our implementation, most of our clinicians reported that they trusted the results from the BAR5 most of the time, which is probably reasonable. And despite our sort of ongoing campaign throughout the implementation, about 20% of our clinicians reported that they didn't know who to contact about the results if they wanted to get further information, which was interesting. And more of our clinicians felt comfortable seizing antivirals and antibacterials. And that was, I guess, consistent with what we saw in our results as well. So in conclusion, implementation of rapid diagnostic panel requires an MDT approach and a collaboration with laboratory clinicians. If you had resources, the pharmacy, we did engage with our pharmacy team, but we didn't have an active sort of stewardship in our study. Implementation is ongoing, and I think even at the end of 12 months, 20% of our clinicians didn't know who to contact. So I think that requires an ongoing collaboration with the clinicians who are using this test beyond 12 months. In our study, implementation of the panel resulted in a reduction in total antiviral or acyclovir doses, particularly the pediatric patients, but there's no difference in mortality of length of hospital stay. And though the overall cost was lower in the BARFA group, would be adjusted for clinical or demographic factors, there was no statistically significant difference.